Hello, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to inform our audience, but also unearth bright spots, successes at health plans, health systems, and other healthcare related organizations around the land. Our goal is to identify as many of these bright spots as possible so that you can determine if the ideas shared during this very episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. If you are just joining us via webinar for the very first time, this is also a podcast. This is a live recording of a podcast. And every Friday morning, we drop a new episode. Almost every Friday, we drop a new episode. And if you have not subscribed to Bright Spots in Healthcare, wherever you consume podcasts, I highly encourage you to do so. So you get to benefit from all the expertise and ideas and bright spots shared by your peers in the industry. We've been doing this show for a while, and there is a lot of really good ideas and content that can help you do your job easier if you subscribe. And you will also enable your peers to reach us more easily. The more people that subscribe, and if you could also, if you like the show, leave us a comment. For example, this was a great conversation that kept me engaged, listening, and taking notes the whole time. This is from a director of pharmacy of quality at Independent Health, a comment recently left for us. So thank you in advance for doing all of that. Our partner in crime, our sponsor today is TytoCare. If you have not heard of them, they are an innovative tech company that helps families around the world who are faced with challenges in accessing healthcare. They help provide that care in the home. They work with health plans to reduce cost of care, improve access to care, and the member experience. And they do this by providing innovative technology inside the home to enable physicians to conduct full exams. I'm going to tell you a little bit more about them later on during the episode. But if you are curious, you could check them out at TytoCare.com. If you haven't heard of them, I'm going to spell that for you. It's TytoCare.com. Visit them there and check them out. We have an incredible all-star panel for you today. I've met with each one of them. They have all kinds of great ideas and examples to provide all of you today. We're going to post their bios both in the show notes of your podcast feed, but also if you're watching live via Zoom, we'll put it into the chat. Jessica Tenzer will do that for us so you can get a sense of the expertise you're about to benefit from. I will introduce them very quickly. You're about to hear from expertise from Dr. Amanda Parsons. She's the Vice President of Clinical Management at Healthfirst. You are also about, sorry about that. I thought I just got kicked out of the show. You're also about to meet Angie Kalousek Abrahami. She is the Senior Director of Lifestyle Medicine over at Blue Shield of California on the opposite side of our country, as well as Dr. Robert Groves. He's the Chief Medical Officer and Executive Vice President at Banner Aetna. And last and certainly not least, representing Michigan, Joe Brennan, the Vice President of the aforementioned cool organization called TytoCare. So thank you all for being here. I want to start with you, Amanda. It strikes me that organizations who, and by the way, my bad, I've been doing this too long. I've gotten a little sloppy. The title of today's episode is Innovations in Lifestyle Change and the Role of Primary Care. So we're going to be talking about innovative solutions, both in person and digitally, and how we could use those solutions to not only support better primary care, but to support better care in supporting all of the consumers we're taking care of in creating tiny lifestyle habits that improve their wellness, right? And we know there's a big focus on this with obviously the GLP-1 groundswell we all are experiencing, but we're not going to just limit it to obesity and weight loss. We're going to talk about all things around lifestyle modification. So sorry about that. The stage is now set. So to enable all of that, it strikes me that all these organizations who are trying to implement these changes, I think maybe shortchange the lift it takes to get any of us to change our habits, even just a bit. And so we often, as organizations, we get underachieved expected outcomes. And so I want to talk about, Amanda, how health plans can innovatively build a culture that enables you guys to have a better chance of success spawning programs that truly produce habit change amongst members. So I know it's a mouthful, but how can we be thinking about strategically changing the culture at health plans and provider organizations to enable this?
So, first of all, thank you so much for having me here. Health plans like Healthfirst play a really important role in the ecosystem, primarily because we view ourselves as part of the healthcare team. It's not them versus us. We're all part of the healthcare team. Our care managers reach out to members in between the appointments that they have to find out more about what they need to be successful. And we approach that incredibly holistically. We address the social determinants of health, their behavioral health issues that they might be struggling with, stress, anxieties, as well as the panoply of medical issues that they might be facing. And we view ourselves as like the in-between care that supports the in-person care that the members are seeking. And that frame helps put us on the same team as the providers. So it makes us interested in what the providers have suggested for our members, and helps us think through what can we do to support that plan? What can we be doing as a plan to remove the barriers, to echo and emphasize exactly what the healthcare community has been saying to the members, and then also making ourselves available to answer any questions that they might have. Some of these appointments can be overwhelming for patients. And so when they have another trusted person that they can talk through with, it's been really helpful. And so I think first and foremost, it's placing yourselves as part of the healthcare team and viewing your role as a health plan in that manner.
That's great. And is there any approaches, like how are you doing it Healthfirst, or have you experienced organizations doing that? I mean, it's easier said than done, right? So how do you get individuals throughout a big organization to truly empathize with what the lives are like of the people that they're helping support and serve?
Yeah. So there's a lot of like squishy things that we talk about in this world, but those can really translate into intentional actions that can be taken. So for instance, poverty simulations. This is something I first experienced at Montefiore and that we've done at Healthfirst, where you can, for several hours, step into the shoes of the members and understand what it's like to be a patient, how absolutely overwhelming it can be to have to negotiate through getting a job, getting your kids to school, dealing with sick children, dealing with bills that have to be paid, dealing with cashing your paycheck and then running right away to go spend it on the things that you need to survive. And the context in which healthcare, like, is trying to occupy a piece of that bandwidth. And it really helps you understand as a health plan that we can't just merely be suggesting or recommending or saying, oh, Amanda, you're missing XYZ or you need a mammogram. We actually have to lean in and help the members get that done, because you can't put another thing on the pile of responsibilities that they have. You have to take some things out and say, let me help you get that other bill paid using your over-the-counter card so that I have time to even get you to a mammogram, and I'm not just going to say you need a mammogram. I'm going to help you schedule it. I'm going to figure out whether you need transportation, and I'm going to take things off your plate so that you have some time and bandwidth to be able to focus on the preventive care and the chronic disease care that you need. I think that is a change in thinking. It's not just saying, let's just be good actors. Let's teach you what you have to do. Let's coach you through it. This is really saying, we've actually got to help you do it. We've got to become like your assistant. We've got to help you get those things done, because otherwise, many of our members are just absolutely overwhelmed with the day-to-day. And even though they are well-intended and would love to be able to do this extra thing, they can't. They just can't. And so that realization of being able to lean in extra hard, have appointment scheduling teams, have like reminders that can go out, have really like be able to connect the dots for the member, sitting with them on the line where they're trying to apply for benefits, not just saying, here, call this number, but like, we'll sit through it with you. We'll help you get that documentation together so that it's one less thing that you have to worry about. I think that frame shift that comes from an experience like a poverty simulation has been one of the many ways that we intentionally bake this into our strategies, our work, and the way that we think about what it means to be successful in doing our work.
I love that. And such an important part of just being able to serve your market is to really understand what your market's going through. And I just think it's lost on many of us in healthcare. So that was a really good example. I want to address the elephant in the room right away and talk about GLP-1s and bring in Angie Kalousek. Ibrahimi is the Senior Director of Lifestyle Medicine at Blue Shield of California. So, Angie, how is BSC supporting members who can benefit from these medications?
Yeah, thanks so much, Eric, and thanks for having me. So at Blue Shield of California, the first thing that we are doing with our members before prescribing the medication is that anyone who applies, we're requiring a 6-month period where they are required to be on a weight management program. In the denial letter that we send out to these members, we point them to our lifestyle medicine platform, which is called Wellvolution. And on Wellvolution, we have sort of a whole host of weight management programs that we have tested and that we know are very successful in delivering results to people who are trying to lose weight. And, this happens through like health coaching, accountability, tracking. So kind of this whole picture of them getting the support they need to lose weight, which many people have not had. They've sort of tried every fad diet out there, been unsuccessful, and thought, okay, I just need to go straight to the medications. Our goal in prescribing this pause, so to speak, is twofold. I mean, first, it gives our members the opportunity to be successful in a weight loss program without the medication, and also the confidence to know that they can do it. They can do it themselves. Some of the members at that point, after the 6-month period, they opt out of taking the medication because they know, okay, I actually can do this and I can make the changes that I need with the support that I'm getting from this program, that I don't need to go to a medication. The second thing we want to do is during that period, we want to educate the member about GLP-1 medications and sort of the implications of what it means to go on them. They are great medications for some people. However, up to 50% of people have really kind of miserable side effects, right? Gastrointestinal distress. Many people start and stop the medications, and I have some statistics on that as well from our data. We have people that don't know that they're going to have to take this medication for the rest of their life. So we want to make sure that they know these things and that they're making a very informed decision. So we have a kind of a second part to this program that we are just about to launch, and that is that when a member decides, or I should say, if a member decides to move forward with the GLP-1 medication, we will then pair them with a virtual specialty clinic. The virtual specialty clinic will help them to get on the right medication at the right dose. And by the way, it may not be a GLP-1. It may be kind of a lower level, sort of an upstream medication that doesn't have a lot of the side effects and so on, if the virtual specialty clinic works with the member and finds that that's the best for them. Then they will make sure that their side effects are mitigated, that they're on the stable dose, and that they are actually getting success, because not everybody achieves success in the GLP-1 programs. So we're hoping that by doing this, number one, we will steer the people who aren't right for GLP-1s to better choices for them, and that those who are right for GLP-1s are getting the support that they need to do it properly. These medications are really expensive, and for an insurer that is, on the hook to cover them, we're looking at our data and we're trying to see what is the best thing for us. We show that about 1/3 of people that get on these medications don't make it to 4 weeks, right? Before 4 weeks, they've started and stopped the medication. And almost 60% don't make it to 12 weeks. So it's sort of like a real catch-22, because while obesity should, reduction of obesity should be something that drives improved healthcare costs, all we're doing is taking money and sort of throwing it away with people that aren't using them properly.
Okay, so that is really good. I want to just summarize. So the strategy here is to create sort of a GLP-1, we'll call it sort of companion program, if you will, is to combine digital with benefit design, aka pre-authorization. So that's number one. Two is, as you get to better understand the data and understanding some people are going to be adherent and some people may not be, to actually make suggestions on potentially alternative medications or treatments for weight loss besides GLP-1s. And for those that are on it, make sure they're in a program that enables them to have the best chance of success and best supportive care. So I think we're in a learning process, it sounds like, but we're combining sort of data, digital, and benefit design to enable lifestyle change.
That's exactly right, Eric. And I think the only other thing I'd add is that there is a percentage of people that get on the medications that at some point want to get off. And we want to make sure that they're doing that safely and that they have the lifestyle to support keeping the weight off, instead of going off of the medication and gaining it back, which is what we're seeing in the trends for people who don't have that support. So that was the only thing I would add to that.
Quick follow-up, and I rarely do this because I know we're tight on time today, but I want to make sure people that ask questions, I could get to most of them, and this one's sort of right on point with what we're talking about. How, Angie and Amanda, you could jump in on this too. Our health plan staffing care management functions to successfully support, needed populations that are, in support, who are kind of you're targeting around programs like this.
So we have sort of outsourced this through our Wellvolution platform. So we're triaging members through that platform. However, many of the members who are in the category where they're taking the GLP-1 medications are also part of our care management program. So our care managers will also be there to help steer them and guide them to the right solution, kind of in that continuum that we've offered.
On our side, I would say, we most of our care management is done in-house, but not exclusively, because there are certain vendor partners that have deep expertise in particular disease areas that we want to leverage. For instance, we have a really good program around like kidney health and others. Certainly some behavioral health programs, some partners who are incredibly good at being present in the communities. They are, working with people who are homeless, or they really have like this special skill set and this a mobile approach that's just, we would do our members an injustice by trying to do that ourselves. But for the most part, our care managers are hired and trained by us because we want them approaching our members with the same philosophy that I was describing before. Some of the adaptations that we're seeing, we have, a cradle to elderly, skilled nursing facility and everything in between. So we have like dedicated teams, like high risk maternity. We have folks who work on diabetes, behavioral health, long-term care, Medicare, and others. Continually evolving those teams is a challenge, making sure that they're, we want there to be a holistic approach. So making sure that they're up to date on all their training from social determinants of health, behavioral health, and complex medical conditions, as well as all of the different treatment paradigms that are changing. We are also working with, digital for some of our members who want to prefer to use digital solutions. We are adding those in. Those have much less traction than our in-person or telephonic work, but still there's a segment of the population that wants to work with us in that way. We also have field-based care management. Some people are just not going to answer the phone. We should stop trying to, you can just go reach out to them. We just have to go see them in person. We have to go find them in the facilities in their homes. And so we have some of those models as well. So I would say for me, a mark of a healthy care management program is there's no one size fits all. There's no one model fits all. And you really need to do a mix of best of breed vendors and in-house, and really making yourselves available nights and weekends to be able to reach out to members and trying to be as available as possible. And then the last point I would say is one of our other values at Health First is being hyper local. So hiring from the communities that we are serving so that you have cultural competencies, shared lived experiences, obviously shared language and others. But, the more that we can be like our members and know their lifestyle, their context, their neighborhoods, the more we're going to have better impact with their care.
It's great. I want to double down on combining sort of technology with the human touch to drive sort of behavior change. And so I'm going to bring in Banner Aetna in just a moment. But before we do, I told you I wanted to tell a little bit more about our partner for this episode, a company called TytoCare. We've been doing this Bright Spot show since 2014. We've grown it, and we can't do it without incredibly great, sophisticated healthcare partners who both provide content and support the show. And TytoCare is one of my favorites. They are a virtual healthcare company that enables health plans and providers alike to deliver remote care to the whole family through solutions like their home smart clinic. So they combine cutting edge, easy to use, FDA cleared devices with AI powered guidance and diagnostic support, and they put them in the home. And this enables the whole family to conduct remote physical exams with a doctor who's remote. So they get to replace these in-clinic exams in the home to provide much better access for many members in different subsets of your market. They drive higher utilization rates, sometimes as many as 6 times or more than traditional telehealth services, and they reduce the total cost of care by an average of 5% by diverting ED visits, urgent care visits, and beyond. 10.8% reduction in ED visits, for example, and incredibly high NPS score of 83. They also have something that they combine with this solution called their Engagement Labs product. And it's a proven framework of sophisticated data and technology to drive engagement around the entire consumer journey, the patient journey, for successful deployment and adoption of their solution and use of the solution. And then they also work with professional settings outside of the home, clinics, schools, workplaces, and they provide something called the Pro Smart Clinic. So really cool organization. They're in 250 plus health systems and plans, and not just the US, although they're mostly in the US. They're also in Europe, Asia, Latin America, and the Middle East. So when you're thinking about innovations around lifestyle modification and support for all the providers that you're working with and all the programs that you're working with, you should just check them out. They're at TytoCare.com. So Dr. Robert Groves is the Chief Medical Officer, and he's the Executive Vice President at Banner Aetna. So I was talking about combining technology and the human touch, Robert. How is Banner Aetna combining that with more, combining your technology with more traditional programs to drive meaningful lifestyle change?
There are a couple of places I could start with that, Eric. One is that, like you've heard Amanda talk about, and to some extent Angie talk about as well, we do use vendors for outsourcing certain aspects of the care that we deliver because there is deep expertise and experience. And so, for example, we do outsource diabetes management, for example, and we are looking at outsourcing obesity management as well. And the thing I like about the strategy that we've used for that, the approach that we've used, is that it is what I like to call, and is becoming more common as a term, continuous remote care. And what I mean by that is that the member / patient, whichever they are at the time, has the ability to communicate with their care team 7 days a week, conveniently from their smartphone or from their computer. They can ask those questions that come up in between traditional doctor visits, and they can ask them in real time when they're actually going to retain that information. In addition to that, there is a community of people who are also sharing the same challenges. They're trying to solve the same problems, and they can share tips. They can share recipes. They can share tips about their exercise and how they got started, et cetera. So you start to build a sense of community among these folks that have a common ground, if you will. Also on available, 24/7 are educational videos of various kinds so that self-learning can take place. When somebody's curious and they have a question, there's a video or there's a paper, a scientific study, whatever you want to see that helps them support the changes that they're trying to make in their daily habits so that they can move towards health. So that's one of the ways that I think we can increase the touch, if you will. Now, it's not real life touch, but the ability to communicate with other members, people who share the same struggles that I do, I think is a huge piece of why it works so well. But we've also begun at Banner Aetna to think about this in a new way. And we have something that we call the ECO, the Banner Aetna ECO, and it is shorthand for ecosystem. And it's an ecosystem of in-person venues and strategies that we have developed after we were so successful with something called the Banner Aetna Kitchen. Now, the Banner Aetna Kitchen is a lifestyle program that is exclusively focused on healthy eating. And so what we do, and we've started expanding it now out from high-risk diabetics to those with obesity, pregnant moms. And so what we do is we set up a cooking show-like experience for them. So they literally are going to a location. We partner with local colleges and businesses to do this. And they have a cook stand. So it's not like they're just watching somebody cook it. They're doing it themselves with a dietitian and a chef in the room. And then at the end of that, and they do this on a weekly basis for multiple weeks. And at the end of that, each session, they take those same ingredients home and cook it a second time for their families. And it has been wildly successful for the folks who attend these. They are excited about it. They're talking to their families. They're teaching their friends. It really is remarkable how much traction we've got on this program in a very short period of time.
I'm sorry, Robert. I'm sorry to interrupt. I want to dive into that whole Banner Aetna Eco program and later on, because this is one of my favorite things I've heard because it's so consistent with what we're trying to do with the show, taking these bright spots. And I want to hear more about the program and how people could think about scaling it. But before we go deep into that, I want to come back to what you were saying in the beginning, because I want to summarize what you said and have you kind of create some clarification for us. So you were talking about continuous remote care, CRC, as I put it in my notes. And part of that is providing 24/7 access to care to your members. And then you combining that with both self-help online education and online community, so peer-to-peer support. And I want to get a sense of like looking at those three things. How does that get executed? How does that look for a member who's trying to, let's say, lose weight and get their A1C down? And is there anything around the gamification component of behavioral change that you added into that?
Yeah, well, when we first started CRC, it was, and by the way, I should also add, Eric, clarify that there's two-way communication. In other words, I can share, and I did the program, so I know a little bit about it. I can share with my caregiver data. What's my glucose today? What's my weight today? What's my blood pressure today? Is there a concern I have? And because it's continuous remote care, that care team, and that would be led by a board certified physician, that care team is available to me at any time if I have a question, and they are able to intervene immediately. And early on in a program, I might be in touch with my care team and sharing information with them 2-3 times a day. Now, obviously, that gets more spaced out over time as I get more educated and better at doing the things that I need to do, selecting the foods that I need to select to stay with the program. All of those things get a little bit better over time. I think that the key here is it is continuous care. It's not just self-education. It's not just that peer group, but I have access, if I need it, to a board certified physician in short order, 7 days a week. And that's what makes it so valuable, that I can ask those nagging questions that I will forget about between 3-month visits. So I think that's one of the things that makes it extremely effective.
Do you have any impact numbers to share with the group, or am I?
Yeah, so let me say that we extended that out. Well, the impact numbers are pretty straightforward, at least for diabetes. 60% of folks coming off all diabetic medication, 66% reduction in total medication provided, a drop in hemoglobin A1C of 1.3, and without calorie counting or anything else, weight loss in the 11 to 15% range. So yeah, pretty impressive stuff. It's not easy, but that's why the continuous remote care is so important to help people stay on track. Now, we extended that to another area. We said, okay, a different vendor, and said, well, if we can do continuous remote care for diabetes, what else can we do it for? And so we took it to one of our local cardiology groups, and they started implementing that to try and reduce the number of readmissions for congestive heart failure, which has been a big problem. And they were able, over a short period of time in a pilot study, this is not the definitive word on it yet, but in a short period of time on a pilot study compared to historical controls, they saw the readmission rate go from 24% down to 14%. And for people that actually engaged with the program, 7.7% readmission rate. So we think CRC is, what we need to do going forward. But ultimately, we think it's a combination of both the in-person field work that Amanda mentioned earlier and that comprehensive community that is developed in continuous remote care.
Love it. Love it. Thank you. That's a great story. I'm going to come back to you, and we're going to get more into the cooking classes and the overall Aetna Eco program. So just stay with me. I'm not, for those of you who are sports fans, I'm not typically into icing the kicker, but Joe, I apologize. It's taken a little while, but I want to get to you now because we're talking about sort of CRC and remote technology. And so I want to talk about the combination of tech and high touch and innovative solutions. And maybe you could provide an example of how a health plan is using technology to not only enable better care in the home for folks with sort of living with chronic conditions, but also supporting patients through data and tracking and making maybe tiny habitual changes.
Yeah, appreciate it. Thank you, Eric. And I think what Robert just spoke to is something that we've seen as a bright spot as well. So what comes to mind is a collaboration between Excellis and Rochester Regional Health. So they too had an issue with congestive heart failure. So many patients, readmission rates, all those struggles that everyone has, they took the same thinking that Amanda talked about was, let's take a hybrid approach to this care management and see if we can potentially bring some of these numbers down. And so they created a program that is both video visit, telehealth, but then also sending community health workers into the home and connecting back to a nurse practitioner. And so utilizing our technology, that NP is able to do a full diagnostic exam with that community health worker in the home. But really, they looked at Excellis members that were Rochester Regional Health patients, and they looked for people who potentially had low educational understanding of what congestive heart failure is, or concerns that they may have with medication complications. Those that had frequent dietary, we'll call them indiscretions, not necessarily sticking to the diet that's going to help them get better. And then those that are homebound and have difficulty getting to an in-clinic appointment. All of these things speaks to why the value of technology and a hybrid approach of, yes, of course, you can go in to talk to your cardiologist or talk to your primary care provider. But if you really want to remain engaged and you want to see those numbers turn around, how do we utilize technology to first right the problem, which is let's improve your diet, let's improve all of those aspects of health that are not where they need to be. And then once you get to that point, then we can talk about how these habits, those little habits that can continue so that you can maintain the healthy lifestyle that you've had. And ultimately, what the goal of the program was to optimize the quality of life of these patients who have now been diagnosed with congestive heart failure, reduce hospitalization. The utilization of the hospital was the metric that they used to determine whether they were going to be successful. And at the end of the day, they wanted to strengthen the relationship between provider and patient and instill those small behaviors that are going to get that patient from being consistently sick to now I live a much healthier and better life.
Yeah, I love that. It strikes me. So there's a breakdown, because I think, Joe, I want to come back to you later on how we could apply this to just other areas, especially around obesity. But if you want to take a bright spot like this one and the technology that you guys provide, I want to get into that another time. But I think there's some research that some of your colleagues sent me for this around this entire Excelis kind of Rochester Regional Health collaboration, of course, with TytoCare and using their platform. So if people want the full case study and get some of the results, I think almost 700 patients in this case study, 46% reduction, I think, in readmissions over 12 months. I could send that to you. We've got both a short video and then a one-page summary of it. So let me know. I'll send that out to everyone, because I do think there's components of the CHF example that could be applied in your lifestyle mod programs across the board, especially around diabetes and obesity. So Jess, why don't we do a poll and we'll send those out to folks for those people that want that piece. Angie, I want to stay with sort of digital support for lifestyle modification and talking about what Blue Shield of California is thinking about, and maybe an example of a program you've been working with where you're leveraging data and digital to drive, what you call lifestyle medicine, if you will.
Yeah, absolutely. And Eric, as you know, we've been doing this for a really long time with our Wellvolution platform. So our Wellvolution platform kind of has a whole suite of digital programs to help members address a range of cardiometabolic conditions such as type 2 diabetes, hypertension, obesity. We have a program for diabetes prevention. We also have sort of a companion program around mental health and mental health programs for sort of subclinical depression and anxiety. And we recently launched a musculoskeletal suite for low, medium, and high acuity members trying to deal with injury and pain from home. And so I love this concept of CRC, and I hadn't heard the term quite in that way before, but we have been doing it for a really long time. And I think one of the things you pointed out, Robert, is this 24-hour access to care gives people the opportunity to engage at the moment that they need it and the moment that they can. One of the things that our platform has not had over the course of time that we've been operating it is sort of a low-level, light-touch prevention app or initiative. And so a couple of years ago, we began working with the Blue Zones company, and many of you might have heard of Blue Zones. Blue Zones is a book that was written by Dan Buettner, I think back in 2004. Dan was a National Geographic explorer and journalist. He went across the country and he found 5 areas of the world where people were living longer than anywhere else in the world. There were centenarians there in higher proportion than any other parts of the world. So what he did was he took the behaviors from each of these 5 geographic areas and condensed them into what is called the Power 9. And the Power 9 are things like, it's not all physical health, right? Some of them are incorporate more movement into your day, eat a plant-forward diet. But there's also things like live with a purpose, connect with the right tribe. Make sure that you take time to downshift or de-stress, whether that be through meditation or connecting with friends. So we approached Blue Zones and we said, and Dan actually wrote a book subsequent to the Blue Zones book called the Blue Zones Challenge. And it was a practical application of how to use this Power 9 in your life day to day. And we said to the team, is there any chance that you could take this book, this Blue Zones Challenge book, and convert it into a digital application? So people in their pocket could have a sort of a tool that helps them track these activities, gamify it, give them points for doing it. And so we worked with them to do just that. And very recently, just a couple of months ago in July, we launched the Blue Zones app. It is proprietary as of now to members of Blue Shield of California. I would expect that Blue Zones will take it to market. And we expected that, but we wanted to be first. And we have about 3,500 members who have taken advantage and growing. I think that one thing that helps members use it and stay engaged is this test that you take at the beginning. It's called the vitality test. And it asks you questions about, your diet and your social life and your habits. And it gives you sort of a projection of how long you will live. You can retake the test after you have done the Blue Zones challenge for a while and see how some of those new behaviors have actually added years to your life, right? It's not a scientific tool, but it's a tool that helps people become engaged. While we don't have a ton of data on like how often people are engaging in the app as of now, I think one of the things we're starting to see is that this is becoming what, for lack of a better word, like a gateway program to some of the other higher acuity programs. Because sometimes people who have a lot of weight to lose, or maybe they have type 2 diabetes and they just don't know, they don't want to take the really hard steps to reversing, they need to do something. And so getting them started in engaging in their health and tracking behaviors on a day-to-day basis can get them to a point where they might say, you know what, I think I am ready to take it a little more seriously and lose the weight or manage my hypertension better or reverse diabetes. So some of the members that are engaging in Blue Zones are going up to the high acuity programs, and that's perfect. It's exactly how we want them to use it.
I love it. I love it. I feel like you got to get access to that app to your friendly podcast host. I think I deserve that. That's a great idea.
Absolutely.
So incidentally, folks, those of you who know me or follow the show know I do try to scribble notes throughout the interviews here. I put in typos, I make all kinds of typing mistakes, but I do take pretty good copious notes. If people want a copy of the notes, they're not professional, they're Eric notes. But if you want a copy of them, what I'll do for you, I'll send these out, but I want a favor in exchange. We love getting feedback. We're getting ready. We're scheduling programming for 2025. We send out in about 5 minutes, maybe even less. We're going to send out another email to all of you to complete a 3 to 4 minute Survey Monkey, mostly all multiple choice, on topics we should cover, how we can be better. And so if you complete that survey, I'll send you a copy of my color-coded notes here, typos included. Now I'll try to clean some of the typos up so I'm not too embarrassed. But if you want those as a summary of today's episode, please just take 3 or 4 minutes, give us some feedback on the episode. I'd really appreciate it. Also, one other kind of administrative announcement, and then Amanda, I want to bring you back in and talk about some of the headwinds. We've got 3 episodes coming up in November that are all super exciting and interesting with all kinds of great guests. One's around HEDIS and consumer engagement and AI. That's coming up next week. We've got another one around post-acute care and innovations there on the 14th, and then right before Thanksgiving, we go back to hybrid care and home-based interventions with some exciting guests. So if you want to come to any of those and not have to fill out the registration form, let us know. You could click on, I think you have the option to click on one, or just we'll register you for all 3. You don't get charged for not coming, but if you want to get in there and just let us do the work for you, just fill out that poll. So Amanda, when you mentioned the poverty simulation in the beginning, and you talked a lot about the inherent challenges people face in creating more healthy lifestyles for themselves and their loved ones, and all the headwinds, could you talk about some ideas that you're implementing at Healthfirst, resources maybe that you're allocating to sort of reducing the friction, reducing the headwinds for your members? Because I think that goes towards sort of lifestyle change as well.
Yeah. So, Angie, I love what you said about the Blue Zones, because part of the Blue Zones recognizes the need for things like social connectivity, connectivity to others, connectivity to this higher purpose. So, as an example, we have an initiative at Healthfirst leveraging a foundation, an organization called Time Bank, which allows people to volunteer, and then you can earn credit hours to receive back volunteer. So maybe you can teach somebody Spanish, but then you need help with your computer. And so it's this like you do this good act of volunteering, and then you receive the benefit of the kind of volunteering act that you might need. And a lot of it is, it's organized in communities, and so people can get connected, meaningfully to other people in their communities, and it can draw out a sense of purpose, especially honestly for our elderly, more like lonely, isolated seniors who still have so much to give. They have these incredibly rich experiences. They have these incredible tools and skills, and like no one to share it with. And so that's an example of like being able to tap into the things that really speak to the skills and talents that our own members have that they want to share with the world, and then for them to be able to get back like something that they need, I think is an example. Another is really
what's the name, Amanda?
intentionally.
I'm sorry, can you tell me the name of that peer-to-peer program?
Time Bank. I can send you some information about it, Eric.
It's called Timing.
Time Bank, like banking time. Time Bank.
I love that. Keep on going. Sorry for the interruption.
Yeah, no. The other thing is really thinking intentionally about our over-the-counter card benefits, right? We have long built in social determinants of health into the benefit structure. So this allows our members to pay off utility bills using their OTC card. That is deeply meaningful to people who struggle to pay that electric bill or that gas bill. And so they can go right onto the, Con Edison and use their Healthfirst over-the-counter card to pay for that electric bill. And that's, we talk a lot about like screening for the social determinants of health and referring, but this is a really tangible way that you can use healthcare dollars to access it. A lot of health plans like us also have added things like the ability to buy, healthy, fresh fruits and vegetables, like go pay your grocery bill with your OTC card, in addition to a myriad of other things. And so I think that intentionality around the OTC benefit is another great way that health plans can be a more powerful part of the healthcare team and provide a lot of value in place to members who may not be able to access that value elsewhere.
I love it. That's great. Two great ideas. But Time Bank, we didn't cover that in the prep call. Angie inspired that. I got to give Angie credit. You get production credit. So just about 13 minutes left. A couple of really important areas I want to cover. And those of you, some of you may know that the origins of this show and this podcast webinar series that we've been doing since 2014 is all based around taking a concept around the power of positive deviance, bright spots, and figuring out how to clone it to solve big problems. And it was inspired by a story that I read about a guy that solved malnutrition with children in the country of Vietnam, or helped solve it. And so these next two questions I want to bring in, like how can we take some of the examples that we've heard from today and scale them and make them powerful enablers for all of you listening to bring to your organization to support lifestyle change amongst the members that need it the most. So Joe, I'm going to bring you back in now. Joe Brennan, VP at TytoCare. We talked about that bright spot around heart failure patients and the impact that program is making by putting technology into the home and providing a way for clinicians to get real-time access to real data that drives behavior change. Could you talk about an example maybe in primary care where we could apply that maybe to patients with comorbidities? Maybe some of those comorbidities are tied to diabetes and weight loss, for instance.
Well, it's very much what you said. The impetus for this podcast was a really good idea that you wanted to spread to others. And the example that I gave of Excellis and Rochester Regional Health inspired expanding past just congestive heart failure. And so we're working with a Blues plan in the Northeast that just started a pilot with 300 patients, but it isn't specific to disease state. It's focused on those with comorbidities more than 4, those that are on more than 10 medications, those that are truly sick, but there is a disconnect between primary care and all of the specialists that they talk to. And so every speaker here has spoken about how important it is to meet them where they are at and enabling them with technology and giving them the knowledge of where their health is at and being able to share it real time with not only their primary care provider, but their specialists and whoever is managing that care continuum, to have everyone on the same page without requiring that person to go into a physical location or talk asynchronously through a chat bot, but actually have that engaged conversation. I think everyone here would agree it's taking what the promise of virtual care is and actually seeing it through. So we've taken the successes we've had in congestive heart failure and we've expanded it to those with multiple diseases. And almost all of the comorbid patients that are in this pilot have obesity. And I think when we talk about what we were talking about earlier, it's such a driving factor in health. And with technology allowing patients to be more engaged with their care team, I think inevitably you will see all of those negative statistics eventually drop.
So, Joe, to me, when I hear about infrastructure devices being put into the home, I'm already kind of anticipating the mindset of our audience, implementation challenges and cost. What does it like cost to get these devices into the home to make this a cost-effective, ROI positive program?
Much less than what people anticipate as far as cost is. It's roughly $15 a month to put a technology in the home that allows to take what is a virtual visit that has its place, but there are limitations. You can expand that by allowing a full diagnostic examination whenever needed. And for what essentially is $180 annually, one missed emergency department visit or one missed readmission pays for that technology for the entire year.
Yeah, that's okay. We're gonna have to talk more about that another time. That's awesome. Incidentally, folks, I'll do this, Joe. I didn't warn you about this, but it strikes me to be a decent idea. If you want to get a sense of like what it would take to create sort of a home-based provider program like this, or just a lifestyle support program enabling providers like this using technology in the home, and you just want to shoot the breeze on implementation process, cost, ROI modeling, and you want to just do a networking call to Joe, I would suggest you meet with them. It doesn't have to be a sales call, but it certainly could be a way that you enlighten you and what you could do to take your digital strategy to the next level. So if you want to meet with Joe, I'll introduce you to him offline. I'll put up a quick poll for that. What the story I alluded to about Vietnam, what was cool about that story and how this guy solved malnutrition in pediatrics was he got mothers, outliers who were cooking certain kinds of dishes to teach their peers, their other mothers, on how to cook these dishes, and it went viral throughout the country without, this is way back in 1990. So Robert, we talked earlier about this Banner Eco program and the Banner Kitchen, and I want to hear more about how you're enabling your members to cook differently, then train the trainer to get them to other members and family members, and how is Banner Aetna making all this work? And then maybe I'll interrupt you and ask you for some results.
Yeah, it's everybody has the same question when we start talking about the Banner Aetna Eco, and it's expanded to include activity where groups visit museums, and this is in person. I mean, they're face to face when they're doing this, when they're cooking, et cetera. And everybody has the same question. Well, how is that scalable? And I think the answer is that there are two things you have to remember. One is that the most powerful marketing is word of mouth. And people that attend these programs, they talk a lot about these programs. And the other issue is the difference between didactic education and what happened in the story you referenced, Eric, which is experiential learning. And this is experiential learning. They're actually doing the cooking in real time. And guess what? They'll go home, they'll talk to their families about it. They'll teach their families how to do it. They'll teach their friends what they've learned. So we're not just creating educated members, we're creating teachers that go back out into the community and spread the word. And its effectiveness, I think, is one of the obvious signs of that is we've had two clients now, businesses, come to us and say, hey, would you set up a program just for us? We'll pay for it. but we want all of our employees to have the opportunity to learn this in this way. And so, yeah, it's viral spread. It's the old-fashioned viral spread, person to person, that we think makes it scalable. Now, we have toyed with, and we may in the future, give it a digital background with community and et cetera, and all of those things. But this, we're about 2 years into it now. We had a year pilot, and this year we've expanded it to include Baneta Active, a catered event called Know Your Numbers that brings people together in person. And if they haven't had an A1C or a blood pressure or some other measure in a while, we'll help them get that done. But I think that we underestimate the power of both word of mouth and experiential learning if we say this is not scalable. I believe it is.
You mentioned Aetna Baneta Active and Know Your Numbers. Start with Aetna Baneta Active. What is that?
So Baneta Active is a program that's based on the same principle as we invite people to come together for a weekly program that gets them back out into the community, gets them moving. I mean, we heard earlier about the Power 9. I think I've always put it in 4 categories: what you eat, how you move, how you manage stress, and how well you sleep. Those are the things that are the primary determinants of how long and how well you live. And so we wanted to make sure that we got movement into this thing. It doesn't mean you have to be, a gym rat. It means that, you're active, you get out there. And so Baneta Active, we might take the group and visit a museum and tour the museum. We might go to a park. Or we might go to a gym and teach them how to use some of the equipment. So it's just a way to get members together to recreate community, person-to-person, face-to-face community, and to teach people how to manage their lives in a better way. And of course, we'll give them hints about, hey, you don't have to get the closest parking spot, to Starbucks every morning. Take a walk. These are things that you can build into your day. Take the stairs instead of all of these little tips and tricks that, and they work together too. I mean, one of the best ways to control a spike in blood sugar is to take a walk after you eat whatever. So this is recreating community and experiential learning. And we think that ultimately it does have legs, that folks will start to talk and teach.
Consistent with everything we've heard, with everything, Time Bank and everything else we've heard today, the Know Your Numbers program, get their blood pressure and A1Cs if they didn't know it. Anything else I should know about that we should know about that?
Well, it's an opportunity for us to meet our members in person, for them to meet other members in person. It's a community project more than anything else. I mean, it's catered. So we have healthy food available for them. People talk to each other. They can get their blood pressure measured. They can get, their A1C. There are other labs that we can do if they need them specifically. And it's just for folks who, want to have a nice meal, talk with other members, and find out what's available to them through their own health plan.
Do you have any high-level impact ROI financial numbers tied to this, or my partner for Active, Know Your Numbers, the kitchen? Any of this yet or not yet?
Not yet. We are in the process of starting to collect hard metrics. When we did it the first year, the question was, is this even viable? It was a pilot program, started with Baneta in the kitchen. We have reports from members, anecdotes, right? I lost 12 pounds. My A1C comes down. We asked them, self-reported on A1C and weight. And what we're finding is that, yes, those things improve based on member reported, but active measurement, hard metrics to get those ROI numbers back is something that's underway right now.
That is great. I know everyone listening live, I'm looking at like, holy cow, a bunch of open questions I didn't get to. There's just so much robust information coming out of our guests today. I didn't want to interrupt. I wanted to make sure we could let them go with the longer answers today, because there were so many great bright spots and ideas. So I'm sorry we didn't get to everything and every question we had planned, but this was awesome. All of you, thank you so much. With 59 minutes, I ask another question, we'll go long, and I don't like doing that for everyone. For all of you tuning in today, whether you're listening to this via podcast or live via webinar, thank you. We do not take the 60 minutes you spend with us each and every episode for granted, and we hope that you use the ideas, the bright spots shared today to inspire your thinking and enhance your company's current approach to improving healthcare for all of us. I really do. We produce this show for you. To our guests, all four of you, thank you so much. I know you worked really hard to prepare, and thank you for the time right now in the middle of your busy day for participating. And for everyone, remember, we produce this show for you. And I always like saying this is your Bright Spots in Healthcare podcast. Take care, everyone.